Ողջույն բոլորին, շնորհակալ ենք մեր միջոցառմանը միանալու համար։ Մինչև սկսելը կցանկանայի կարճ հայտարարություն անել երկլեզու թարգմանության վերաբերյալ երկու լեզուներով, դրանից հետո կշարունակենք անգլերենով, քանի որ ինչպես հայտարարվել էր, միջոցառման լեզուն անգլերենն է։ Ուրեմն շատ ուրախ ենք բոլորի տեսնել Հայաստանի Ամերիկյան համալսարանի ձեռներեցներ առողջապահության ոլորտում ծրագրի շրջանակներում իրականացվող հերթական գիտական քննարկումներից մեկի շրջանակներում։ Շատ ուրախ ենք տեղեկացնել, որ միջոցառումն առաջարկելու է երկլեզու համաժամանակյա անգլերեն-հայերեն թարգմանություն, որպեսզի դուք կարողանաք դրանից օգտվել, հարկավոր է սեղմել ձեր Zoom էկրանի ստորին աջ անկյունում գտնվող Interpretation, երևոտ, թարգմանություն կոճակի վրա, որի վրա որ գլոբուս է նկարված, դրա վրա սեղմելուց հետո դուք կտեսնեք երկու լեզու, անգլերեն, հայերեն, հարկավոր է պարզապես ընտրել այն լեզուն, որը որ ցանկանում եք լսել, այսինքն օրինակ, եթե խոսնակը խոսում է անգլերեն լեզվով եւ դուք ցանկանում եք լսել դրա թարգմանությունը հայերեն, հարկավոր է սեղմել հայերեն, արմենիան, արմյանսկի կոճակի վրա։ Բացի այդ, դուք հնարավորություն ունեք թողնել կամ անջատել օրիգինալ ձայնը, հա, այսինքն եթե դուք ոչինչ չսեղմեք, ոչինչ չանեք, պարզապես լեզուն ընտրեք, ապա կլսեք օրիգինալ խոսնակի ձայնի բարձրության մոտ 30%, եւ դուք հնարավորություն ունեք դա թողնել կամ անջատել։ Դրա համար հարկավոր է սեղմել, անջատելու համար հարկավոր է սեղմել լեզուներից ավելի ներքև գտնվող Mute Original Audio, выключить оригинальный звук կոճակի վրա, որպեսզի դուք չլսեք օրիգինալ ձայնը։ Անկեղծ ասած, կարիք չեմ տեսնում նույն լավ, ապահովության համար փորձենք շատ կարճ նույն հայտարարություն անել անգլերեն լեզվով, որտեղ ես չեմ տեսնում մեկ մասնակցին, թե ինչ լեզվով խոսացող մասնակից է, այնպես որ թույլ տվեք նաև անգլերենով այս կարճ հայտարարությունը անեմ եւ շարունակեմ։ So, welcome dear participants to the sequential scientific discussion session organized within the framework of Entrepreneurs in Health program of the American University of Armenia. Before launching the actual events, let me announce that we're glad to offer simultaneous bilingual translation, English-Armenian translation, in order, but the language of event will be English. In order to use the translation, there is a need to press interpretation button located in the right bottom corner of your Zoom screen and simply choose the language of your interest. And for example, if the speech is in, for example, in Armenian, someone asks a question in Armenian and would like to hear English translation, simply press English, choose English language. And you also have opportunity to mute original audio. Otherwise, you will hear about 30% of the volume of the original audio. Please do not hesitate to contact me in case of any questions, technical questions. Very well, I guess we can start. Welcome everybody. As I said, this is one of the monthly scientific discussion sessions organized within the EIH program. And today's session is dedicated to healthcare quality assurance and will be led by Dr. Vahe Kazandjian. And let me present short biography of Dr. Kazandjian. So I'm very glad to inform you that Dr. Kazandjian is one of the EIH program's executive committee members. So he was with us from the very beginning, from the very roots of EIH program. He's currently an adjunct professor of the Health Policy and Management Department of the Johns Hopkins Bloomberg School of Public Health, Baltimore, Maryland. He is an epidemiologist by background, by training, and served as an advisor to different international organizations, including World Bank, including USAID and World Health Organization. He is also, he previously was principal at the Outliers Health LLC, which was a consulting group assisting healthcare organizations worldwide in achieving accountability through performance measurement. Besides that, he served as senior vice president at the Maryland Hospital Association and as the president of the Center for Performance Sciences. a Maryland-based International Outcomes Research Center. He is an original architect and the director of Maryland Quality Indicator Project. Dr. Kazandjian has presented more than 450 conferences on measurement of quality of care, epidemiological investigation methods, as well as accountability about quality of care. He has authored 4 healthcare quality related books and more than 70 articles in international peer-reviewed journals. This was all. This was a short biography. I mean, the biography is really diverse and comprehensive. I tried to sum up the most important points. This is all from my side. Related to some technical announcements, please do not forget to mute yourself whenever you do not speak. Besides that, let me remind you that, as was previously announced to everybody, this session is being recorded, and participation in this event means consent of this meeting to be recorded. This is all from my side. Thank you very much. Dr. Kazandjian, stage is yours. I'm about to launch the presentation.
Thank you very much, Asik. It's a pleasure to be here. Ողջույն բոլորիդ, շատ ուրախ եմ, որ պիտի գարենանք միասին ժամուկես անցնել այսօր, անգլերենով բիշարունակեմ.
Sure.
So the goal for today's presentation is to discuss the issue of quality from an angle that maybe not everybody thinks about all the time, which is to see how you can distill, how you can minimize the resources and the knowledge that you use to measure quality and use it to improve the health of patients, communities, and regions. My presentation is not gonna use any numbers, statistics. I'm gonna discuss the concepts for you so that you can remember the concepts more than you can need to know about numbers or statistics. So with that as a background, let's have the first slide, please. That's not the first slide.
Excuse me, please. I'm trying to solve the issue.
Yeah, thank you. So if you look at this picture, depending on how you would like to interpret it, you have possibly a person down there and somebody is trying to hit that person. Next one. Here's another approach to that, and this person is being hanged from the legs down. Third one. Here they are squeezing the chest of that person. Next one. Here they are trying to put some air into the mouth and the lungs of that person. I'm assuming by now you realize where this is going. Next one. If you go back to the last one, thank you. So, so what we have here is the history of cardiopulmonary resuscitation. So people knew that they had to do something in order to bring that person back by having air in the lungs, but they did not know the best way of doing it. So parsimony, as we are going to be discussing today, is really like this. You start with a complex approach because you don't know exactly what to do. And over time, you realize what is the best way, the most effective way to get the outcome that you desire. So quality and research in general is a little bit like cardiopulmonary resuscitation, if you want. You try different approaches, you try different methods, and if you are lucky or if you're good, you will end up with the most effective, elegant, and parsimonious approach to achieve an outcome. Next. I will return this later on, but if you don't remember anything from today's discussion, I hope you will remember this. This is a simple way of making decisions about everything, practically everything we do in life. When you look at an issue, if you look at the top left box, you make a decision if you are doing the right things wrong. This means that you know what the right things are and you find errors and you correct them. In industry, as well as in healthcare, this is called quality assurance. So quality assurance is that you know what is the right thing to do. You have the ways of checking if you are doing the right things, but you check if those things are done, what is the percent of error in what you have done. The next one under it, it says doing the wrong things wrong. This is very possible, especially in the area of safety of care. You can you can give the wrong medication to the wrong patient at the wrong time. So doing the wrong things wrong is not uncommon, but it is not always measured because people don't think about it very much. The next one is the bottom one on the right. It says doing the wrong things right. This is very important for quality because you can do surgery on people who do not need surgery, and you can do that very well. So the surgery can be very well done, technically, but the person will not need that care. It is called unnecessary care. And then there is the top one, doing the right things right. Doing the right things right is a summary of the three other boxes. It means that you know what are the right things and you can do it well. You can do it in the right way. And that eventually is what quality is all about. Next one. This is a game I like to play just to see how people react to things. I have used this around the world for many, many years. And in your mind, since we are not interacting face to face, in your mind, make a decision as we go along. Uh, Keep going, please, Asik. So, as you can see, there is a target. Like, keep going. And okay, so there are three people um, trying to hit the target. The distribution is, as you can see, the first one has one in the red circle. That's A. B has nothing in the red circle. C has nothing in the red circle, but has a different type of distribution. So when I asked this question to different audiences, immediately everybody says that C is the best performer, that they trust C. And they trust C, let's say, as a bodyguard, because of consistency. If you look at C, the top, there are 4 hits that are very close. So consistency is believed to be very, very important for quality. Most people next like A because there is one in the target, and B, people think it is random performance and they don't like it. So let's look at this from an epidemiological point of view. You have 6 points in time. It could be 6 points during an epidemic, every month statistic, or it can be a person's performance in, let's say, infection rates in the patients, and or it can be a hospital's performance. In many ways, this is called a report card. A report card is what shows a performance in a very simple way. Now, if you look at those three, consistency is a very interesting idea, but you have to understand that you can be consistently wrong. So if you remember the previous table, doing the right thing is important, not necessarily doing it well. So the right thing is called appropriateness. Doing it well is called effectiveness. And that's a relationship with the process. So what if C is very consistent, but is consistently doing the wrong things? What if A has improved, if you look at the sequence of the X's, has improved over time and eventually got to the target? And that's called performance improvement. And B seems to be random, but the idea is, what is the target? If you look at the target in quality or in healthcare, it can be 0% infection rate, it can be 3% C-section rates, or it can be 45 minutes of waiting time. The target is different for different people, for different regions, for different conditions. So when you look at this, it's almost an epidemiological analysis of trend analysis, of looking at performance improvement and deciding if the appropriate outcome was achieved. So those are things that we need to keep in mind when we're looking at quality and quality improvement. Next. So here are the questions that I mentioned. What was the sequence for each shooter? Did somebody start in a way that was not very good and then improved? You need to look over time. You cannot just look at one picture. That's called time analysis. What was the variation in the distribution? That's called, the error and the variation between the different performance points. And who is the most consistent? Next. So what is the target? What is the target? And this is a very important thing if you are a decision maker. For example, in many situations, governments do set standards or goals for healthcare. And the question is, how did they decide on the targets? For example, today we are having a lot of difficulty with COVID-19 with the goal for vaccination. What is the target? Is it 70% of the population in order to achieve herd immunity? Is it 50%? Is it different segments of the population? So if you don't know the target, you cannot assess the performance of a system, of an individual. And knowing the target is not easy because
Եվ թիրախն իմանալը հեշտ չէ, որովհետև առողջապահության ոլորտում բազմիցս թիրախները
with evidence that is achieved in the field. It's called evidence-based knowledge. So when evidence-based knowledge changes, it can also change your targets. Years ago, it was believed that if you are really a good hospital, you will have 0% infection rates. That is not possible. It's a good message to send, but it is not possible. So you have to be realistic and you have to be consistent with adjusting to the changing targets. Next. So in looking at performance measurement, there are two types of errors. There are unpredictable ones and there are constant errors. Unpredictable ones are the ones that environmentally, in the situation where care is provided, be that because of technology, be that because of resources, those errors can happen. And then there are constant errors. There are errors that do not change. There are errors that are due to a person's constant performance. You see this a lot in surgery. You see this a lot in healthcare services that deal with a very narrow approach to the service. If the person who is providing is consistently making the errors, that is something that cannot be changed in the sense of finding the variation in that performance. Probably it has to improve the person or change the person. So looking at errors, there is not one type of error in measurements. There are different types of errors that depends on the person and the environment. Next one. So how do we evaluate healthcare performance? Now, realize both in Armenian and other languages, the term evaluate has in it the term value. In Armenian, it will be arjevorum and arjek. So how do you decide what kind of value you are going to put on what you are saying? So in order to evaluate, you have to first identify your goals and targets. In order to do that, there is something called indicators, as you all know. And indicators are standard measurement methods that quantify, that put a statistical value, a measurement value on the performance. They don't say if it's good or bad. They just say this is what it is. It's quantification versus evaluation. There is no value in statistics. The interpretation of statistics puts a value on the statistics. The second one is the measurement of expectations by patients, providers, or community. It's very important to have those three together because expectation is, I will come to that a little bit later, is a situation that has two variables. What you want and what you get. Think about this. What you expect is the difference between what you want and what you get. If you get much less than what you want, then your expectation is not met. So in order to talk about expectation, and that takes us to the next one, you need to talk about satisfaction. If and satisfaction can be misguided or appropriate. For example, uh, if I say to all patients, if you are diabetic, you are going to lose a leg or an eye, and they do not lose an eye or a leg, they will be very satisfied. But was that satisfaction based on true expectation, or it was made up in order to show performance? You see that a lot in different services, and around the world, one of the most common one is C-section deliveries. It was always believed that C-section will give the baby a better chance for development. Hypoxia or lack of oxygen for a long time before delivery was believed to be taken care of by C-section. So that expectation and that satisfaction is an approach that the healthcare system needs to also be an educator, a true educator for the patients and communities. And then we have to, therefore, part of the impact is the education. Healthcare and quality is not only providing services, but also educating the actual or future patients of what to expect. So there you have, quality is an approach that deals with the role of the providers, not only as technicians, if you want, or people with knowledge about health and disease, but also people who understand their communities and patients and provide them the correct expectations. And that's why quality becomes a partnership between patients, providers, and communities. Next. So, having said all that, we have to measure things. We cannot just say, I really believe that I'm doing well, or trust me, I can do the best things for you. Those are good things to say, but when you are going to be talking about performance and quality, you have to measure things. In order to measure things, there are three ways, if you want, you can measure performance. You can start with what you want to measure. I want to measure every readmission because of previous care. Okay, that's a target, that's a goal. Or you can focus on performance aspects that we can actually measure. There are a lot of things that are not easy to measure or that we don't have the knowledge or resources to measure. And the third one is performance aspects that are measurable. For example, when it comes to subjectivity. Oftentimes subjectivity about, I like my doctor because he or she does this. We all know about how patients evaluate their care. One of them is bedside manners, or sometimes a very simple thing that my doctor knows my name. So when you take all those three dimensions, the intersection between them is what we can measure. So you take those three, the intersection, and then once you define that intersection, you can define the indicators that can measure that intersection and the way that you can interpret them. Next. I mentioned all of these, but now this is a way of putting it together. So we start with appropriateness. Remember, the right thing. It was appropriate, the right thing to do. It's very important. Without appropriateness, it's not important that the process was good if you are doing the wrong thing. You start with appropriateness. Then the question of achievability. Can it be achieved? Can it be done even if we know what is the appropriate thing to do? The third one is effectiveness. Effectiveness means that what you did had an impact that you can relate to what you did. So if something is effective, you should be able to link what you did with what came out of it. We're going to come to this a little bit later, but think about the relationship between process and outcome. That relationship is very important in any kind of production, in industry, in healthcare, in literature, in personal relationships. What you did and what happens, if you can link those two, and to a certain extent with confidence, then you can repeat those and achieve again a good outcome. So it will be achievable if you can link effectiveness to process. As you can see, I'm trying to put a lot of relatively complicated concepts into a framework that is distilled, that is minimally complicated, and that comes close to the title of today's discussion, which is parsimony. Parsimony is doing things with the least complication, with the least resources, but do it in a way that really has an effectiveness in the approach. There is a saying, it says, the golden rule of science is parsimony. Science, true science, takes all the complex issues and distills it into an elegant, parsimonious approach. Remember the cardiopulmonary resuscitation. We don't need to hang people from their legs or beat them in order to achieve what we know we should achieve. It is very elegant. It is very effective. Next. I'm sure all of you have heard this definition. It has been used a lot, especially since safety of care in the past 20 years or so has become a worldwide goal, that appropriateness is doing the right thing for the right person at the right time. So those are three things you can measure. And once you measure each one of them, if you put them together, you can have an understanding and a definition of appropriateness. Achievability is how do you make it operational, the most desirable outcome. What is the most desirable outcome? It is an outcome that is based on knowledge, on evidence, but also, remember, but also on the expectations of the patients. Patients have expectations about health that deal with their understanding of their quality of life. Patients will not understand Biology will not understand chemistry, they will not understand surgical procedure, but they will understand that they have a certain type of quality of life expectations, and that's what they want. A lot of joint and for example, hip and other things replacements, shoulder, hip, and they have to do with patients' expectations on quality of life. Many of them will postpone surgery if they can take the panel, they can take the less of a movement. If they are not gonna go hike mountains or go skiing or playing with their grandchildren. So their expectation has to be met with our knowledge of the evidence. Effectiveness is the best value for the available knowledge, which means that the available knowledge says if I do this, this is the probability of the outcome. I didn't say 100%, I said probability. So probability means that you can do the right thing for the right person at the right time, but still there may be less than optimal outcomes. And that's the challenge with healthcare compared to making shoes. Making shoes in a factory has the same approach. It has to have the relationship between what you do and what happens. You have to have quality assurance to find defects in the product, and you can provide new technology and new knowledge to those who are providing it. But that relationship is almost 100%, whereas in healthcare is probabilistic. And we always need to keep that in mind when we are evaluating, when we're putting a value on what we see happen. And finally, subjectivity. We can never leave subjectivity out of this statement of quality, because there is subjectivity by the providers, there is subjectivity by the decision makers, by the policy makers, and of course there is subjectivity by patients and families. I remember we had one person in a study that said that her physician, her obstetrician, gynecologist, was the best obstetrician she has ever had, because she had 6 infections during the hospitalization, and he was able to treat all 6 of them. And when we asked her, but don't you think that you should not have had 6 infections? And that's not how they think, because that's not the logic of a patient, if you want. What they see is services rendered that improve their quality of life, and they appreciate that, even if it was done in a way that was not appropriate. Next one. In order to achieve science, and in order to, in this case, be able to measure it via indicators, we need to have a common language. For example, all 3 of those are called a football. They are not the same shape, they are not the same weight, they are not played the same way, but they are used, they are defined by the same term. So terminology becomes very important, and it's called standardization. So in order to start thinking about quality, you have to have standardization in your approach. If you are comparing physicians, nurses across regions, across hospitals, you have to have a standard measurement system. There cannot be variations in the measurement. Why? Because the most important thing in understanding performance through measurement is comparison. It's called comparative analysis. If you are going to compare, then you have to use exactly the same definition, the same tool, the same way all the time. If somebody says, oh, this is how I always did because, I was trained this way and I'm very good at this. That's not any ways you can use as an approach for measuring and comparing performance. So we have to have the same language, we have the same terminology, and we have to use the same standard tools of measurement. Next. As you heard, I have done a lot of work using epidemiological thinking, epidemiological tools, because I think it's one of the most easily understood ways of inquiry and analysis. You probably also know that in epidemiology, when you are looking at understanding an event, an outbreak, or whatever is under consideration, there are W's: who, when, why, where, what. You have to answer those questions, and then you can relate the observed to possibly the cause of what happened. So based on that, years ago, I put together a 5W approach that has been used a lot in this field of quality. And the first question you have to ask is, where am I? Where am I means, what is my profile of performance as a dentist, as a pharmacist, as a physician, or as a hospital? What is my infection rate? What is my readmission rate? How have I improved over time? Can I define my where I am on all these areas? Those are called indicators. Each indicator measures a certain aspect of performance. And when you put it together, it will tell you where you are on those, and you can trend it over time. So where I am is a position analysis. You start with that. If you don't know where you are, as they say, any place you go is fine. If you are going someplace, you need to know where you are first. The second question, after defining where am I, is why am I here? The why question deals with cause, reason. Why am I here? Can I really understand why am I having 5% readmissions for things that I should not have any readmissions? Why are patients not happy with my performance? And so on and so forth. The why question is an introspective analysis. You go inside to understand the why question. So the first one, you look at where you are, that's on the outside. You can measure those statistically. The why deals with processes and structures. Oh, I cannot do this because I don't have the resources. I don't have the technology. I don't have the trained nurses. I don't have the trained technicians, and so on and so forth. That's the why. Now that I know the first two, then I can say, this is what I want to be. I want to be the best in this area. I want to have this kind of an outcome. Where you want to be is also a message that individuals or institutions provide to their community. You are going to say, I'm going to be the best hospital in orthopedic surgery. Why are you saying that? Because you can show the first two as a background. So now that you defined where you are, why you are there, and where you want to be, you need to make sure that you have or can get what you need to achieve these. And this deals with knowledge, education, training, technology. And the fifth W is what has been accomplished. You have to show eventually what has been accomplished in order to be able to be evaluated so that people put a value on your performance. What has been accomplished is an impact analysis. So if you go to the next one, please. So when you start looking at indicators, we go from anatomy to physiology, if you want. The first W, where am I, is anatomy. Physiology begins with the why question. Then you start understanding what are the things that have happened or can happen in order to change some of your performance and maybe even your anatomy. So we're coming close now. As you can see, I'm building the case for distilling all these concepts and bringing to the most elegant, to the most simple, but to the most effective piece of knowledge that we need to have in order to start dealing with quality and expectations. Next one. This is something that if you can keep going till the, yeah, one more. Yeah. So this is something that I've used extensively as well to put some of those things into a picture. I love pictures, as you can guess, because this is what people remember. I could have shown all this to you in statistics, in numbers, in graphs and all that, and probably by the end of this session, you would have remembered only one or two things. But when you look at pictures, it stays in your mind. And I try to put gradually everything we discussed into sequential pictures. So let's start with the left circle. It says indicators of performance. So from a very basic point of view, the starting point for defining indicators can be clinical. We all know this. Can be organizational, resources, people, structure, or can be economic. What kind of impact it has had on the economic situation of the region. Now remember, when you talk about economic impact of performance indicators, suddenly you can bring in a lot of other measures that have nothing to do directly with healthcare. Indirectly, they do. For example, employment status, productivity. A healthy population is a productive population. So it builds nicely into this general picture. In the middle, you have that balancing act, as I mentioned, between expectations and satisfaction. If your expectation is 10 and you get 8, then your satisfaction can be measured by that gap between 10 and 8. And that is called a gap analysis. If your expectation is 10 and you get 12, then your satisfaction is excellent. So remember, satisfaction is a function of goodness of expectations. If you have unreasonable expectations, then satisfaction will be also unreasonable. And that's where the education of the healthcare system comes in to provide the right expectation. Let's go to the circle on the right. So the indicators are quality of life and functional status. Those are the ultimate measures of a good healthcare system. It's not infection rates. Those are important. Those are the building blocks. But eventually, quality of care is measured after the patient leaves healthcare system. Think about this. It's not something that in most situations people think about it. People think about quality as limited to the length of stay, to the encounter. But a true indicator of impact is afterwards. How do you know that a joint replacement was successful? Is it because the surgery went well? Is it because there was no infection? No. It's because 6 months later, the person is playing with his grandchild. That is the impact analysis. Now, when you put all this together, you end up with an accountability approach, that you have to be accountable for what you have done. So all those measurements build into an accountability. Now, in English, the term accountability has its origins in French. And in French, it's compter, which is to count or to measure, which means you cannot be accountable without measurement. Accountability requires objective, not subjective measurement. You cannot say, trust me. Trusting is not part of accountability. Accountability is showing that you have done the right thing to the right person at the right time. Next. Now, this brings us to the question of elegance in science. There is a whole literature that deals with elegance in science. And elegance, this is an article by a faculty member at Johns Hopkins University that has a nice visual to it. That's why I'm using it. And the 5 pillars of this temple to elegance, if you want, are defined as clarity, cleverness, correctness, ability to explain, and finally, parsimony. We touched upon all of these, but for very quickly, the clarity has to do with unambiguous. There should be no ambiguity in the measurement or in the goals for the measurement. Cleverness is how clever the method for putting all this was together. It has to be the imagination behind it and the ability to put complex concepts and ideas in a very clever way, and do that in a correct way. Something that could be verified, can be checked, and that it can be explained without having secrets in the methodology or the approach, that it is obviously clear and transparent. And finally, parsimony. Parsimony, as we defined, is using the least of resources of any kind to achieve the goal. Next. So, how can we put all this together and talk about elegance? As we discussed, for example, between expectation and satisfaction, the gap analysis tells you if the satisfaction is in response to expectations. And the same gap analysis can be done between the 5 pillars. If you look at correctness and cleverness, how close are those things? If there's a large gap between those approaches, then perhaps the elegance in general is not optimal. As I just said, the gap between those 5 pillars is important. Next one. And this is what I'm talking about. This is the gap. This is a gap analysis. And this person has a big gap, if you want, and has to figure out, how to deal with it. And that's what we deal in research as well. This gap, we need to identify it and figure out what it means for the methodology and what it means for our interpretation. Next one. Now, I know all of you know Avedis Donabedian. He is correctly known as the father of quality in healthcare. And I had the privilege to be his last formal student at the University of Michigan. And he has written extensively on every aspect of quality, but in a very interesting way that deals with elegance, parsimony, correctness, and cleverness. He has put together all of these issues that he discussed, that we are discussing today, into what is known as Donabedian's trilogy. And that is structure, process, outcome. Now, at first, you would think, well, that's very logical. But it is amazingly elegant to be able to put all these two concepts together in those 3 words, in the sequence of 3 words, that are really different from industry, but they are very specific to healthcare. Let me explain it. Structure, we all know what it is. Structure can be a building, can be a room, can be a operating theater, or can be resources available or staffing. Structure is what you have available to provide a service. Process is, again, we know that, how those structural and knowledge components are processed to achieve a desirable outcome. Now, in industry, the concept of structure and process exists. In industry, a similar one will be called structure, process, output. But Donabedian realized that output is not outcome. The difference between output and outcome, according to his explanation, which is accepted throughout the world, is that an output is a value-free statistic. An outcome is, I produced 500 shoes. But in healthcare, an outcome is what an output is evaluated as good or bad. This is where the subjectivity comes in. This is where quality of life comes in. This is where appreciation of the healthcare comes in, or disappropriation of the service. So keep in mind, it's very elegant, but it is not immediately obvious that we're talking outcome or output as you would be in producing a product in industry. It is more than a product. It is producing health, producing quality of life, functional status, and appreciation. And that gets very complicated. It's much easier to measure an output than an outcome. Okay, next one. In all this, in the past 20 years or so, there has been a lot of discussion about safety, quality, and productivity. And my approach to this, in a lot of the work that I've done around the world, I have come to believe that if you define safety as different from quality, then you create a challenge to the providers and a challenge for accountability. Remember, accountability is the ability to count and to demonstrate how you have done. You cannot demonstrate a safety outcome without having looked at quality. You cannot look at quality without looking at safety. I mean, there are still people who propose that there should be safety officers in a hospital and a quality officers in a hospital. I think that's fine as long as they work together as a team, not that safety is seen as different from quality. And I've published quite a bit about this and talked about it in very, very different places. Safety is part of the process of providing quality. Next. So quality improvement and safety improvement, there's really no distinction. They have to be hand in hand. The construct for the measurement of an indicator is really the same. It's an epidemiological construct. It has a numerator and a denominator. The numerator is what you observe. The denominator is what was at risk, who was at risk for that observed in the numerator. You do trend and pattern analysis the same way you would do for an outbreak. And you will be able to compare across time, across region, across services. There is no difference in the measurement construct. Indicators, gap analysis, impact analysis are part of the measurement. Next. When we talk about both safety and quality, we obviously talk about errors. And that's what we were talking about, doing the wrong things or doing them wrong. They are part of the constant and variable errors, as we discussed at the output. So when you start looking at clinical domains, you have adverse drug events. Nowadays, everybody somehow knows about this or looks at it on a continuous basis. Hospital-acquired infections, complications of surgery are among the uh, 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 the most common areas. But there are other things that should be looked as well. For example, performer fatigue. This is not looked at on a regular basis, but it's very important for errors. We know that errors come with fatigue. So if we look at that as we are looking for errors, we will increase our ability to improve performance. Information transfer. More and more information gathering and sharing is becoming daily routine. Years ago, it was very complicated affair to have an information system. Now it's not. So looking at information transfer, if the right information was transferred at the right time, so that the service that was provided did not commit an error based on knowledge of the person's background, is important. Next one. So looking at this is an important domain that could be included in any indicator measurement system is information technology, what type, how it's used, how it's updated, human factor research, how is the providers, the hospital, the individuals using new science, new technology, how they are interacting with them, and organizational theory, which brings some sociology into this of understanding internal communication and working together capability between physicians, nurses, pharmacists, and patients, for example. Next. You know, when technology changes, we change with them. And human resources research, for example, how we interact and what it means for us, have to be also looked within the framework of how we have changed in our knowledge, in our habits, in our understanding with technology. So this is just a kind of an easy way of making that point, that we should not only look at technology as the size of the technology in the TV set, but also who have we become in our interaction and what that means. Next. Now, talking about distilling things to the minimum and being parsimonious, this is something I like. This is the way I look at things. It's quite simple, but it has the capability of being measured very well. Leadership is doing things because you have to, before you have to do them. Anybody can do things when they are forced to do it. So if you waited till the time that you were forced or demanded or to do something, you're not a leader, you're a follower. So leaders do things before they have to be done, which means that a lot of people say, why are we doing this? We don't need to do it. That is the challenge of leadership. It is also called a vision. You cannot be a leader without having a vision, without being half a step ahead of everybody else. If you're 2 steps ahead, nobody will understand you or follow you. That's not good. Half a step is good. You can convince a lot of people with half a step. 2 steps, you're too far ahead. So in all this, we need to also think, how do we identify leadership in the measurement of quality, in ability to communicate about it, and do things that are not so radical that nobody wants to follow you. It's a big challenge. It's one thing to be a great visionary. It's another thing to be somebody who can apply that vision. A great visionary is not a leader. A great visionary is a great academic thinker. So, something to think about. Again, it comes back to parsimony. It comes back to our ability to put things together and to share it with people who are not there yet, but that we want to get them on board. Remember, half a step, don't go too far. Next. In a funny way, leaders always are different. As you can see, that duck in front is the leader, doesn't look like the followers. So from a statistical point of view, think about a normal curve. In a normal curve, you have three very important areas or concepts. You have outliers. Outliers are the ones that are in the tails of a distribution, as you know, 2%, 2.5% on each side. And then in the middle, the bulk of the distribution are called inliers. Those are the ones that are, not noticeably different. They are in the group. And I like to say that there is a third group that you don't learn about in statistical books. So you have outliers, you have inliers, and you have liars. And the liars, which are a very big problem for performance measurement, are the ones who are always at the middle of a distribution. They somehow figure out how to fake the numbers, how to show no variation. There is no way you can find no variation over time in a performance. So if you have outliers, that's where your leaders are. A leader is never a liar or an inlier. A leader is an outlier. So if you are going to be a leader as an outlier, then you have two possibilities. You can be a good leader or a bad leader. But you're still a leader. So our challenge is, how do we train people to be outliers in their thinking, in their education, in their ability to have a vision, but also be good outliers? And that's part of the education and support system towards quality. Next. Here's a cartoon that deals with this question. This deals, as you can see from the bottom, this is from 20 years ago, year 2000. And this is when the whole question of quality and errors started. And this was published in Modern Healthcare, which was a leading, probably still is, journal. So you have the hospital board of directors, you have the chairperson, chief executive officer, and so on and so forth. And then you have the quality control. And you have the cartoon that shows like the three monkeys, hear nothing, see nothing, say nothing. And this was the approach then. The approach was, hey, errors happen. We cannot stop things from happening, and we should not accuse providers or institutions of not being good just because there are errors. That errors are part of the service. Well, that was 20 years ago. Things have changed. But there are still areas around the world that this remains relevant. So we need to keep this in mind, that we don't have a system that is like this, that basically says, hey, it happens, we are not going to worry about it. Next. This is a different way of talking about leadership and our target groups. You have, as I said, you have leaders, but they can be status quo. They can do everything to not change. Most of us are in the middle. We will follow one way or the other. And then there are leaders of change towards better quality. And the leaders of change are the ones who not only understand the basic concepts that we're talking about today, but they have reached themselves a way of communicating it in an elegant, parsimonious, and effective way. A good leader has to have one-liners. You have to have something that people remember and identify with. Talking about things in paragraphs or for hours and hours, you lose people. So you need to, in order to have those one-liners that are effective, you need to really understand the concepts. So leadership fits nicely with elegance and parsimony, as we are discussing today. Next. And this is quite obvious. Uh, New ideas or people may not be ready to adopt. Um, People, structures, uh, 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 we need to be patient for the change. But we need to make sure that we really believe that change is needed and we can show why. And we have to have a wider view and understanding of the new situation. Next. Now I will give you a minute here to look at this picture. Not more than a minute. I assume that most of you will see a lake, rocks, and a couple. But if you have a way of having a wider view, you will see a baby too. Unfortunately, I cannot interact with you through Zoom, but if you look above the trees, yes, thank you. You can see the face, the arm, and the legs of the baby. So this is just a way of saying we are trained to focus on a logical point in what we are observing. But we need to have that wider view of looking at the entire picture. And I think I have one more slide coming up, maybe two. Here's another one, and this is a saying that every medical student hears during the third year of medical school, is that when you hear hoof, you have to think horses, not zebras. We are all excited about being exotic, of thinking about things in a very unusual way. We think a lot of causes, a lot of connections are because of an unusual event. That's not how we should approach quality. When we hear hoofs, when we see certain things, we need to think about the most common reason for it, not an exotic reason. Sometimes it's not very exciting, but I think it needs to be part of our training to look at the basic performance issues. Next. And we're back to where we started. So if I was able to systematically go through the concept, then you should be able to decide for yourself when you look at an issue, if you know what is right and you can identify what is wrong. If you don't know what is the right thing, then don't look further. Try to figure out what is right. Don't forget to look at wrong things being done wrong. That's a part of the safety approach. Doing the wrong things right is a big problem if you look only at outcomes, because the outcome can be great. But as I say, the patient may not need the surgery to start with. And if you look at the outcome of the surgery, you will miss the point about quality. And doing the right things the right way is our ultimate good. Okay, I think that is my way of trying to put some complicated issues together. And if there are questions or any discussion, I will be happy to take them.
Thank you very much, Dr. Kazandjian. It was a very interesting presentation. Initially our event is planned until 6:30 Armenian time, but I assume a question and answer session might take a little longer. And thus, if the speaker, you, Dr. Kazandjian, and the participants do not mind, we can stay for 10-15 minutes longer if it is okay with everybody. So if there are any questions, please, you are welcome to ask those. You can either raise your hand or just jump in with your question. Alternative option is writing down in the chat so that I can read out loud. Any questions? Dr. Armenian, please.
Yeah, very nice presentation, Vahe. Thanks for all the ideas that you have put so succinctly together. Just I wanted to make one remark regarding the leadership and visionary. From my own personal experience, Avedis Donavidian was a visionary, but he was not a leader. And I think you realized that when it came to real life problem-solving situations, he tried to shun away from that. That comes up on a number of occasions when I invited him, for specific consultant, as a consultant or other, problem-solving situations. But again, we need not just the leaders, but also we need people like him, the visionaries, who set the pathway for for the future. And the visionary is maybe 2 or 3 steps ahead, but we need someone to think about those 2 or 3 steps ahead. He dedicated his series on quality of the books, and he used to say that there is so much in there that future generations will discover rather than people who are reading it in the 1970s on that. So I think my copies of those 3 books are at AUA now. in the library. And it would be nice for anyone on the audience to go to those books of these that have not been explored appropriately by people. Thank you. Thank you again, Vahe.
Thank you,
Thank
Dr. Armenian. If I can make a couple of comments, I see. Yes, you are right. He was. That's why I said that there are academic, if you want, visionaries who are 2 steps ahead, and there are leaders who are half a step ahead. It is interesting. By the way, just for the record, I have to tell the audience here that Dr. Armenian was my first professor, and he is the one who introduced me to epidemiology, and I'm grateful for that. You know, the thing about being half a step ahead. I remember when this was back in the 1990s when I first started international work on quality indicators. Avedis Donabedian sent me a letter. He always wrote by hand with a black pen, and I have a few letters that over the years he has sent me for things like that. But he has sent me a note that I really kept very close, and sometime I look at it. He said, "What you are doing is vulgarizing," and it's not a bad word. Vulgarizing means making it common, making it accessible to the larger audience. And he said that he was never in that situation of making it for the wider audience, simplifying it if you want. And it's kind of an interesting word that for most people, they will think of it as vulgar, but it has nothing to do with vulgar, but means to make it common. And that's what I'm talking about, is to be just a little bit ahead, to speak the language that most people will understand, and to distill the concepts into something that after you leave the session, after you leave a program, there are 2 or 3 lines that stay in your mind. And every time you have an opportunity to think about this topic, those lines come back. And that's why Avedis's trilogy is so elegant, because no matter what culture, no matter what language you are, it sounds true, people remember and keep. So that's a very good example of elegance and parsimony.
Thank you. Any other questions? I think I did not miss any in the chat box. So if there are no more questions, I would like to ask my question, if I may, Dr. Kazandjian. When you were talking about the trigger and trajectory model, something came to my mind. Do you think we could, like, it would be reasonable to draw parallels between this model and Deming's PDSA cycle, plan, do, study, act cycle? And if yes, perhaps in this case, it would look not like a cycle, but like a spiral. Do you think it would be reasonable to make comparison, to draw parallels between those 2 models?
Yes, that's a very good observation. It is, in the sense that any kind of rational, any kind of approach that can be duplicable and repeated, therefore scientific, has to be rational. And rationality implies that there has to be a understandable relationship between steps, that what follows builds on what precedes, and that the impact of what follows on a goal can be measured and established. So those approaches, all of them follow that logic, that it is a scientific approach, that you have to plan and, and so on and so forth, like Deming said. The PDCA cycle is more of a process than it is a starting point and ending point. So the process that he has is a constantly circulating process. And the more you circulate that process, the more you can improve it. And therefore, the relationship to performance improvement. What I showed there has that because of accountability, but also has the trigger that necessarily is not necessarily in the Deming. The Deming model assumes that something exists, and that what exists you can improve and make it better through the cycle. Whereas what I'm saying is, I'm not assuming something exists. I'm looking at what makes something become existent. And the trigger is that. The trigger is what makes that happen. So I'm one step before that. So we need to understand what is the trigger, and then do what you mentioned about different spirals, cycles, whatever the image is for improvement. But I'm not assuming that we know what exists.
I see.
And we need to measure what exists. And that's something that, like we were talking previously, for years I discussed this topic in lectures, till at the end of almost 10 years, I realized that the title of the presentation should be, if you want to think out of the box, you need to know what's in the box. So out of the box thinking is leadership, is vision, and all that. But most people don't know what's in the box. How am I doing is in the box. Why am I there is in the box. So understanding what's in the box and what triggers that should come first before you go into improving it or looking at it.
Okay, thank you, I see. Dr. Armenian, please.
Yeah, the word accountability has a nice Armenian option, hashvedvutyun, which is very much the same word, and that we use at least in other contexts. And also, what Astrid mentioned, I have always managed to see things in this spiral of educating, implementing, and then moving to another level of performance or quality. And that's not just for healthcare, but also for education and in everything in life. You're moving it, hopefully you're moving as a spiral rather than you're on a flat surface.
Definitely. Thank you. May I ask another question, Dr. Kazandjian?
Sure.
So, well, the process of defining targets for measuring performance in healthcare and in any field actually was always kind of a challenge for me. I do not quite well understand how do we come up with targets well, I know that we can use international evidence, scientific evidence, previous experience, and so on and so forth. But I would like to use this opportunity and ask you to elaborate a little more. What is the best way of coming up with targets?
Well, it has to involve more than healthcare. It has to involve expectations of recipients, expectations of payers, expectations of quality of life. So it is a very narrow thinking, which is not bad, but it is narrow, to only focus on the short period of time, which is the encounter with the healthcare system, be that length of stay or a visit to a clinic, as the time frame within which a target should be defined. A target is much more than that. A target is, as I mentioned, the true outcome versus the output. So keep on thinking about that distinction that Donabedian made between output and outcome. It includes the importance of having a target that goes beyond the healthcare system encounter. And quality of life, productivity, and so on and so forth, functional status, are part of that. So you can start by looking at obvious outcomes, which are immediately within a very short period of time during that hospitalization, let's say. And that's fine to start with. But eventually, if you're going to make a difference, if you're going to educate your customers, if you want, it's interesting because, you know, in English, the term client and the term clinic are the same. They come from Greek, which says kline. Kline means a client. So the whole concept is that you are dealing with clients. I know we don't like to put it that way. It sounds like it's not healthcare, but a client is the one who expects a product. What we have done in healthcare is that we have put the client at a disadvantage because of the knowledge we have that the client doesn't have about the production of that product. So it's a long way to answer your question that outcomes can have different layers, levels, but eventually just focusing on immediate outputs rather than outcomes does not follow the obedience model.
I see. Thank you. Just to clarify for the audience, why am I so curious and ask that question? Simply, you know, because in many parts of the world, in many healthcare systems, let's say, well, not in many, in some healthcare systems, whenever there is target-based performance management, performance measurement in healthcare, it kind of sometimes, and particularly if it is associated with some reward or punishment, it sometimes creates soil for data manipulation just to meet targets without thinking about the eventual outcome and so on and so forth. So that is why I'm curious whether it's okay to use targets for measurement, measuring performance, and well, it is okay to use them, but it's indeed challenging to come up with certain targets. That's why.
That's a very good point. And you just gave an example for what I was saying, that the third group in a distribution are the liars. And the liars are the ones who are going to manipulate the data, as you put it. So we need to keep that in mind. So you have the leaders, you have the outliers, you have the inliers, but we have to keep an eye on the liars because they are the ones, as you very well said, that are going to misinterpret the reason why we have targets. And therefore, we need to be able to educate them and work with them that the targets are going to serve a common goal and they are not a punishment. They are just a necessity to be able to improve them.
I see. Okay, thank you very much. Any final questions from the audience?
Just thank you.
You're welcome. Thank you.
Okay,
Thank you.
I guess, thank you. I guess the time is up, even the additional time of 15 minutes. So our webinar is over for today. Please follow us on our official platforms. I mean our website, our official Facebook page, as well as AUA different official platforms for being informed about upcoming scientific discussion sessions. And we do hope that we will have many other sessions dedicated to healthcare quality assurance and improvement and management. This is all for today. I wish all of you a very nice evening or the day, depending where you are currently, from which part of the world you joined us. And yes, this is all. Thank you very, very much for joining.
Սրդակոն շնորհակալություն բոլորիդ եւ բարի օր։ Շատ ուրախ եի, որ միասին գտնանք ժամուկես անցնել։
Շատ շնորհակալ։
Շնորհակալություն, շնորհակալություն։
Շնորհակալություն.
Goodbye.